I'm going to talk with you right now about shoulder disorders. And we're going to start by talking a little bit about anatomy. And I want to do a little compare-contrast to the hip because these two joints, although they're both ball and socket joints, boy, are they different. The hip we talked about being a really resilient, strong, architecturally sound joint. The shoulder is basically the polar opposite. There is a ton of bony instability. The great thing about the shoulder is no matter what direction you want to pick apples, you want to play craps, you want to dig, whatever you want to do, this thing goes in all hemispheres and can do all kinds of things. The downside of that is there's not a lot of bony stability around the shoulder. So unlike the hip, it doesn't take a tremendous amount of force to dislocate the shoulder. Just a poorly timed high five with a friend in the wrong position could get you there. So let's chat a little bit about why that is and a little bit about shoulder anatomy. So I had a mentor of mine once describe the shoulder sort of like our families, just a little unstable. And the reason for that is that when you look at the shoulder blade, the scapula, it's sort of a free-floating bone without a whole lot of articulation points, right? This big thing that is the shoulder girdle, it's connected to the axial skeleton only by the sternoclavicular joint. And then the other points of articulation are your glenohumeral joint, and then you also have your AC joint. But other than that, there's not too much. A lot of mobility, but a lot of instability. And if we're looking at the bones here, some of the key players, you have the sternum, you have the clavicle. The clavicle then articulates with the acromion, which is a part of the scapula. Below that, you have the coracoid process, and then all the way laterally, you have your humeral head. In terms of muscular anatomy, the big muscular players here, the rotator cuff that you often hear about, the subscapularis on the front side and anteriorly, and then on the back side you have the supraspinatus, infraspinatus, teres minor, and then you have your the bicep, which the tendon, the long head of the bicep tendon goes through the bicipital groove up there. And the last thing that I want you to take notice of is just below the acromion, you see that little blue thing? That's the subacromial bursa. And that is going to be a key player as well when we talk about some causes of shoulder pain and some of the pathologies. This is just another anatomical photo with some of the first photos, some of those layers peeled back. Some important concepts. So we've already talked about the bony instability. We've already talked about how a lot of the shoulder is connected by the soft tissues, the muscles, the tendons, the ligaments, and less so by the bones. The last really important concept here is that when you injure the shoulder, that it doesn't tend to happen in isolation. The shoulder doesn't tend to have, you get a dislocated shoulder, you tend to also get rotator cuff injuries. Or you get a fracture and you also can get a dislocation. So that's pretty common with the shoulder. In terms of the shoulder exam, if you've ever looked up how to do a proper shoulder exam, man, it takes like 10 minutes to do this thing comprehensively and the right way. But I want to give you guys sort of an approach that's something that we can do quick, easy in the emergency department that gets us through most of it without having to spend an exhaustive amount of time, like more than you would for a stroke evaluation. So as with all physical exam things, we start with inspection. So the first thing I urge everybody to do when somebody has a shoulder complaint is don't let them sit there with their shirt on and the sweater and their starter jacket and just pull that thing off. Like get everything off, put them in a gown so that we can kind of take a real good look for bruising, ecchymosis, any deformities. You might even pick up a case of zoster as for shoulder pain, and we do a good inspection. Palpation. The way I like to palpate the shoulder is to start medially at that sternoclavicular joint, at the axial skeleton, and work my way out to the humeral head. So I'll often start with the sternoclavicular joint. If you have, sometimes you can get clavicular dislocations over there in high energy mechanisms. Start there, see if there's any pain, move along the clavicle, palpate where the AC joint is, see if that's a source of pain. And then you can move down into the humeral head, into the bicipital groove. And then finally, you're going to want to get to all the range of motion exercises. And so what are the range of motions? So the ways that I think of it is you have flexion, which you can go pretty high, extension, which can get you back about 40 degrees, abduction, sort of snow angel, adduction, and then you want internal and external rotation. Those are sort of the cardinal movements that you're going to want to go through. And we'll talk about how that relates with rotator cuff injuries and specific injury patterns as we move through the talk. Strength testing is going to be important. Sensory testing, you'll often hear about the axillary nerve. There is actually, it says good video, so it is pretty good video. It's a YouTube video if you want to see the comprehensive exam. There are just so many special tests that you've probably heard about in your, in your training or reading about the shoulders, the Jurgensen's, the Neers test, and all this kind of stuff. I don't want you guys to memorize all those, but it is good one time to kind of go through this and see what the spectrum of physical exam is for the shoulder. So we'll start off with AC separations. AC separations tend to occur, you guys have probably all seen these, tend to occur in people that they fall off a bike or something, or fall off one of these Lime scooters where people are getting injured all the time. They fall off and they just didn't have time to get that hand out. They otherwise would have had a foosh or something like that, but they go and you get a direct blow to the AC joint, and that can pop your AC joint out of place where it articulates, the acromion articulates with the clavicle. Now there's different gradations that you can see here on the illustrations. Grade 1s, grades 2s, not so big of a deal. Grades 3s also sometimes can be non-operative, and then as you go up in your grading system, it can get worse. So what really distinguishes these grades? Let's kind of focus in here where you see a normal AC joint. There is the articulation between the acromion and the clavicle. That's your AC joint. And then from the clavicle to the coracoid, there's another big ligament there, the coracoclavicular ligament. And those are stabilizing. So in a grade 1, grade 2, you only have the actual AC joint. You won't see this disarticulation. But if you get a grade 3 and that CC ligament also gets affected, look down there, you can actually see the AC stepping up. And then grades 4s through 6s have to do with, is there skin tenting? If there's skin tenting and it's puncturing through the skin, that is when we call ortho. We typically don't need to call orthopedics. This is usually a sling and refer type of injury. But if you start getting skin tenting and that is a problem, or it's like badly comminuted and not just tenting but poking through the skin, those are the kinds of things that you would want to call ortho for right away, but that's very, very rare. Shoulder impingement syndrome. This is another entity that you're going to probably hear about. How do we diagnose it? How do these patients present? So, and why do they present like this? So shoulder impingement syndrome, we talked about the acromion, we talked about the humeral head and the subacromial bursa. That space, there's a lot of anatomical variation amongst everybody here, sitting here today, and myself. Everybody's going to have a little bit of a different space in there. It tends to be sort of only millimeters big, and when you have a tighter space between your acromion and your humeral head, that space can get irritated. So a lot of structures go through there. Your supraspinatus tendon goes through there, your biceps tendon goes through there, you have your subacromial bursa. Any of those structures, once they start getting inflamed and irritated, especially in people that have anatomically tighter spaces, they can get something called shoulder impingement syndrome. The way you're going to look for this on exam, we talked about sort of doing abduction. They call it the painful arc syndrome. You start ranging them all the way through, and they're going to get points of impingement here, and they're going to be uncomfortable, whether you do it passively or actively. And it's a little bit unfortunate with shoulder impingement syndromes. A lot of times you can just give them like NSAIDs, you give them ice and physical therapy, but it can resolve with rest and exercise, but sometimes it can take 6 months or so to resolve. But again, this is an outpatient diagnosis. The way that outpatient referral, you won't see much in the way of X-ray. You'll just have to understand that, like when you're starting to get pain in that subacromial bursa region and pain in that region, this is a potential diagnosis. Again, you're just seeing the anatomy that's coursing through that subacromial space right there. A variant, so a different entity here, which is calcific tendinitis. Calcific tendinitis, the way that this sort of presents is also they get this painful arc syndrome. The only difference is the X-ray is negative for the shoulder impingement syndrome. In calcific tendinitis, you're fortunate enough, how many shoulders do we image and we just get nothing? We don't see anything, and you have to tell the poor patient, rest, ice, we don't know. There's some soft tissue problem over there. But calcific tendinitis, you can actually show them where the problem is. And so you can see here the supraspinatus tendon, or like the distal part of the tendon of the long head of the bicep. Those things can get calcified, and you can actually show the patient. So the good news is you can tell them what they have. The bad news is this one can take sometimes, it can go away. Even you get this in like a 35-year-old, 40-year-old, we don't really know why it happens, why this calcifying process happens. But after you tell them, hey, good news, we know what you got, bad news, it may take 3 to 5 years for this thing to disappear. So sometimes patients live with this thing for long, long periods of time. What can you do for it? Again, physical therapy, NSAIDs, ice. If that doesn't work as an outpatient, a lot of these can get injections. I know some ED docs that like to do the injections themselves. There's some variability in practice there. And then, if they fail all those things, there's interesting things that they do. They can do these like needling procedures where they lavage and all kinds of weird stuff they can do in there to help these patients because they will have it potentially for a long time. Biceps tendon rupture. A biceps tendon rupture, these are pretty readily apparent. Usually the mechanism here is somebody who is carrying, trying to flex a lot of weight against resistance, and then you hear the sudden pop. And the tendon, where it tends to rupture, if you remember, you have a proximal insertion, so you have the distal insertion at the elbow, you have the proximal insertion where we saw at the bicipital groove. The far more likely place for it to rupture is up here at the bicipital groove. What do we do for these? Big deal. They can develop these like Popeye arms and real deformities, and you think, my gosh, we got to get this thing fixed right away, refer it right away. Actually, these patients tend to do pretty well. They don't need really urgent referrals. There's not much to do. Most people actually preserve a lot of their strength from the short head of the bicep, especially when it happens proximally. The people that you do want to refer is if you get, like, if Devin Booker or Giannis, like one of these famous basketball players, they get an athlete, a high-functioning athlete, and they need to preserve every little bit of strength that they have. Those are the patients typically that get referred for repair. If you get a distal rupture, those need to be a little bit more urgently referred. The reasons that people can get these: fluoroquinolone use, steroid use, especially if you have the combination of fluoroquinolone and steroid use. So you have a COPDer who just had an exacerbation, they're on steroids, you've given them a dose of, you shouldn't, but you give them fluoroquinolones on top of the steroids. Those are people that are at really high risk for rupture. The interesting thing about fluoroquinolones, if you give somebody a course of fluoroquinolones, how long after you give them the fluoroquinolones are they at risk for rupture? Is it just while they're on the course? Yeah, right. So they are at highest risk during the course and a little bit after the course, but up to a year after, they can still be at risk for these types of things. So something to consider. Thoracic outlet syndrome. If anybody's ever diagnosed thoracic outlet syndrome, you get the Diagnosis of the Year award. These are tough to diagnose, tough to pick up. But really, the way that patients will present here is sort of like arm heaviness. They'll have a extracervical rib sometimes, or some tightening in that space in the thoracic outlet where the arteries, nerves, and veins course through. And there's 3 different types of thoracic outlet syndromes. What are they? They're arterial, venous, and neurologic. And they all present a little bit differently. You could imagine somebody with an arterial thoracic outlet where the primary problem is the artery being compressed. Those patients might have some pallor, heaviness, almost like when you get claudication of your leg, you hear that kind of story. It'd be sort of claudication of the hands and arms. In the venous types, I don't know if anybody's ever seen this, a case of like Paget Schrader. They might be thrombosing because of this. You get that compression of the vein, and then they can start getting swollen. I've seen a few of these where you get a young guy playing basketball, and all of a sudden he's coming in with this big thrombosed arm. He doesn't have a PICC line in there. There's no other real reason for it. It's just an overexertion type of injury, and they'll just come in with a big swollen arm compared to the other one. Those need to get referred, and then the neurologic type where they get numbness, tingling, and all that kind of stuff. So how do we test for these? There's 2 tests that are often described. There's the Adson's test and the East test. It's really important to know the Adson's test, you're having them sort of like twist their neck over toward the affected side, and you're feeling for the radial pulse, and they start losing that radial pulse. That's concerning for an arterial thoracic outlet syndrome. But you're not testing for the other types, but using the Adson's test. The other thing that you can do is the East test. You have them do this, sort of the funky chicken type of thing, and you have them do this for about 3 minutes, and if they start getting numb, like pain, heaviness, tingling, that could be neurologic, arterial, or sort of a combination of those. So you get somebody with unilateral arm pain, heaviness, those kinds of things, thoracic outlet syndrome is the thing to consider. Clavicular fractures. So we see a ton of these. These are unfortunately very common. And these are a result of falls to the shoulder. We just had a resident that we had, at a retreat, fell by the poolside and had a pretty well-displaced fracture of his clavicle. Fortunately, it's unfortunate that they're commonly fractured, but fortunate in that most of the times these things do well with just a sling. Now, there are certain times where you need more than a sling and that we're a little bit more concerned. Where are the majority of these clavicular fractures? Are they medial, middle, lateral? Yeah, the mid. So the majority of clavicular fractures are right there in the middle of the clavicle and don't need too much intervention other than sling and referral. But if you get tremendous amount of displacement, even in the middle, and again, skin tenting is the thing that you're going to be wanting to look for, that needs to be an ortho call. The problems with medial fractures are, or you can have sternoclavicular involvement. There are great arteries and things over there. So if you get a high energy mechanism and you see a clavicular fracture over medially near the sternum, I'd have a very low threshold to do some more advanced imaging and make sure there's not other big injuries there. And then in terms of function, when it gets out closer to your shoulder, closer to the AC joint, and that's disrupted, and you have a clavicular fracture there, that can destroy the integrity of the shoulder girdle. Those also need to be evaluated, not emergently, but need to be evaluated by ortho. So do you guys remember these figure of 8 splints? We used to put all these clavicular fractures in this very complicated figure of 8 splint that would fix your posture and help with your clavicle fracture. And we found out actually that a simple sling is much better. These figure of 8 splints actually will cause more skin breakdown. They have poorer healing. So please don't, if you have them in your ED, please don't use them. A simple splint is much better. We talked about both AC separations and we've talked about clavicular fractures. You'll often see people put them in slings. The sling, where you really want the majority of that pressure, you'll see them kind of slung down here, which is fine when you have like wrist problems and that kind of thing. But really where the point of comfort is, you want to raise that sling up so their shoulder isn't like really moving around. So if you can get it up and make the point of pressure at the elbow, it helps with patient comfort. Rotator cuff syndrome. So everybody's probably heard about the rotator cuff. The rotator cuff is a very well-known player in the shoulder. Baseball players, you'll often hear like overuse injuries and whatnot. On the way here on the plane, I actually had these slides pulled up, just kind of doing a final review of the shoulder talk. And the guy next to me, he looked at me, he's like, I don't mean to be nosy, but I have this thing in my shoulder. I felt a little pop, and you think it's a rotator cuff? And so actually on the plane, there was nobody between us. We went through and did all the maneuvers and everything. And I was like, it's fine. It didn't feel like it. He was a little tender going up on abduction. He might have a little bit of impingement. I told him, he was like, I'm so sorry to bother you. And I'm like, I'm just happy it's the shoulder and I'm not, looking at an anorectal lecture or something like that. So I was just fine with doing the shoulder exam on the plane. So how do these present? So there's 4 different, we talked about the different rotator cuff muscles, and the different rotator cuff muscles are, you have your subscapularis, supraspinatus, infraspinatus, teres minor. Each of them can be tested in isolation. We often think about rotator cuff injuries as being limited in abduction, and that is true, and that will happen when you have a supraspinatus issue, which is up top, just above your scapular spine. But there are some other provocative maneuvers that are really good to know, and basically the 3 provocative maneuvers that are simple tests to do. Abduction, looking for supraspinatus, and then all you got to do is get them internally and externally rotated against resistance. If they're limited in external rotation, then that's concerning for your teres minor infraspinatus. If they're having difficulty against resistance internally rotated, that's concerning for a subscapularis on the anterior side. So not too many maneuvers, but some special maneuvers to help you with diagnosis of this. Why does this happen? The rotator cuff is in its most vulnerable position when you're up here, sort of in the high five or baseball throwing position. And so any kind of repetitive stress in these positions can cause stress, where you can see all the tendons are inserting there on the humerus. And the humerus is, like I said, at its weakest point in this position. You can see these vector diagrams. We're not going to go through physics, but... And one of the things that is a related topic to a rotator cuff injury is this shoulder dislocation. So how many hip dislocations have you seen in the past year? Maybe 1, maybe. How many shoulder dislocations have you seen in the past year? A lot. So shoulder dislocations are far more common than hip dislocations. We talked about hip dislocations being very commonly pushed back through a vector posteriorly. Anterior shoulder dislocations are the opposite. The anterior is far more common, the posterior far less common. And then you can get these inferior dislocations as well. And when you see somebody with an anterior dislocation, you get this squared off shoulder appearance. You guys are probably familiar with this. Somebody just holding their shoulder and not wanting to move it at all. On the x-rays on an anterior, you'll see the anterior sort of pushed in more medially, depending on the view that you're getting. But you can see that, that anterior dislocation, a little bit medial and anterior. So how do we evaluate these? The really important for all of these injuries is distal neurovascular exam. Where you definitely want to focus is making sure that they don't have any numbness around their deltoid where the axillary nerve is. And then in terms of relocation, getting them prepped for reduction, hips, we need to knock them out. We need to knock them out and get all those like muscles relaxed and whatnot. But because of the lack of stability in the shoulder, if you get them, I don't know if anybody's ever had somebody, pop a shoulder out skiing or snowboarding or something like that. I mean, that's the moment to get them back. If you can get them back right then and there, the muscle spasms hasn't really set in, and you can do a pretty quick, easy maneuvers and pop them back in. The longer they wait, the harder it is to get that thing back in. But the really beautiful thing about getting these shoulders back is we don't need to put them under propofol sedation every time or procedural sedation. Sometimes just an intra-articular thing, or hopefully a little later we can show you this Cunningham technique, which is, has anyone done the Cunningham technique? You sit, you kind of stare into the patient's eyes and you relax and they get a free massage and also their shoulder tends to pop back in. So there's some cool low stress maneuvers that don't take a lot of resources with nursing and pharmacy to be able to do. And then an interesting point about whether or not we need to get pre-reduction films. If you've seen enough shoulder reductions and you see somebody and they have the squared off shoulder and it sounds like a shoulder dislocation, smells like a shoulder dislocation, you've seen 100 of these, do we really need to get shoulder films? So definitely with the people that have chronic dislocations, they've dislocated their shoulders multiple times, I think that you are just fine not getting films on those. For a first-time shoulder dislocator, it's sort of, again, some variability in practice, but there is, there's experience and evidence to suggest that it's probably okay to not have to get the film, unless you are concerned about a really high energy mechanism or a concomitant fracture or something like that. The one downside of getting pre-reduction films is if you have a really busy radiology department, the longer we're sitting there waiting for these pre-films, the more that they can spasm up. But it's not totally unacceptable to get the pre-reduction films. Post-reduction films, I get every single time just to make sure that I've gotten everything back into place. So older patients, I actually get films every single time. Sometimes you think it's a shoulder and it's actually their proximal humerus and there's all these associated fractures and things, so I don't mess around. But younger patients, it looks and smells like a dislocation, then we're fine. So I'm gonna give a brief overview of some anterior shoulder techniques. There's sort of the paradox of choice. There's almost too many choices when it comes to anterior shoulder reduction techniques. So I'm going to kind of pair them up like 3 general categories that you can use. There's no one technique that works best for everybody, just because the way that the shoulder dislocates usually goes to like the inferior rim of the glenoid fossa and anterior. So, and depending on what position it's in, different techniques could work better. So let's talk through a few of the different techniques, and they're all sort of listed here for your for reference, but we'll go through them individually. Stimson and scapular rotation. This is nice when you have a super busy emergency department that's just bumping and you don't have time to do the whole evaluation. If you have weights in your emergency department, you can have them sit prone, lie down prone, attach the weights and just have them hang for a little while and let them sort of relax their muscles on their own. You don't even need a tremendous amount of sedation, or you can give them some Versed beforehand and just kind of let them sit and relax. And then you can kind of combine that or separately just do a scapular rotation. I have intermittent success with scapular rotation, but the way it tends to work is if you can feel the inferior tip of the scapular spine, you want to really move that medially the way that it's shown in this photograph. So the Stimson and scapular rotation are a couple potential techniques. Fairs and Spazo. We're going to talk about the Hennepin and Milch, which is far like my preferred starting reduction technique, but the Fairs and Spazo are also totally reasonable. The FAIRS technique stands for fast, reliable, and safe. So Hopefully, it's fast, reliable, and safe for you. The way that this works is you get them out into sort of external rotation, abduction, and then you waggle them. You get them up and down like this, and you kind of like try to loosen the humeral head off the glenoid fossa and get that back into place. Spazo is sort of a variant of that. You have them laying supine. You get them up into this sort of like vertical position, and you give gentle traction, and you just internally, externally rotate them and hope that the humeral head pops back in. I don't use these too often. Amongst yourselves, I would talk and see if people have used these things. They're worth trying, and they're well described and have pretty good efficacy. Hennepin and Milch. The Hennepin and Milch techniques, I like this a lot. This is something that I've been using since residency and tends to work pretty well. You get the patient out into external rotation. This is the Hennepin. And you start them in abduction, and that tends to work a lot of times. If that doesn't work, then you can get them into this Milch position, which is often described again as like sort of the apple picking position. So you get them into a Hennepin, and if that's not working, then get them all the way up into this Milch position. The last technique that's not featured on these slides is this Cunningham technique where you sit on a chair, you have the other person sort of like eye to eye with you. You have them put their hand on your shoulder, you put your hand on their sort of scapular spine, and you have them relax. And basically what you do is you start massaging these muscles that are starting to spasm. You massage their sits muscles, their supraspinatus, like the trapezius muscles, the bicipital groove, deltoid, going down to the bicipital groove. And just doing that for a few minutes and having conversation with a patient can sometimes pop it in. So it's not featured here, but I'd encourage everybody to take a look at it and try it. That's like a really nice sort of initial technique as well, the Cunningham technique. Things not to do. So all of these positions, anything that you look at in a book, you open up Roberts and Hedges or any book, and you see somebody sticking a foot in somebody's axilla, don't do those things. Those are high risk for axillary nerve damage, and just in general, just not favorably looked upon when you're like shoving your foot in someone's armpit in the emergency department. The Coker technique, which used to be done fairly frequently, external rotation, you bring them back out into internal, that's also higher risk of axillary damage, so try not to do that as well. The posterior shoulder, we're gonna move on from anterior to posterior. The far less common version, how does this one happen? Posterior shoulders tend to need more high energy force to dislocate and are often missed on x-rays. Why? Look at that. The glenoid and the humeral head actually look like they're pretty well aligned. The problem is just the morphology of the shoulder is not the way it's supposed to be. It looks more like a light bulb in this photo, or a drumstick, like a chicken drumstick, sometimes they'll describe it as that. But if you see that, and typically the patients that get this are somebody who's been having status epilepticus or seizures, convulsions, and then they'll come in and you're working on the convulsions and you get you get an x-ray for whatever reason. Sometimes these are missed. The other way that you hear it described is sort of like lightning injuries or really bad car accidents. This is the last one, luxatio erecta. Has anyone seen this? This is pretty interesting pattern. It's an inferior dislocation that's like a variant of anterior. The patient actually looks like they're coming in this very dramatic pose. It's like the back of the hand, the palm to the forehead sign, so luxatio erecta. And it's fairly easy to put back in. You just take them in the position they're in, and you do inline traction, and that'll get them back to where they need to be. These ones are unique in that they have a lot of associated rotator cuff injuries. Finally, we got some adhesive capsulitis and frozen shoulder, and patients who get dislocations, if you throw them in a sling and tell them to be like not do anything with their shoulder for the next 6 weeks, this is something that can develop. This is why when we have people leave the emergency department, you put them in a sling 1 to 3 weeks and you start having them do range of motion exercises, because if you don't, it can start to prolong the mobilization, can lead to this adhesive capsulitis. That capsule around the humeral head gets stuck. And then when you do that painful arc, they actually they can't. They can't passively or actively range their shoulder. It's a frozen shoulder, and that's not a good place for patients to be. So often we'll send people home with these Codman's exercises. You'll see people like, you'll put a hand on the wall with one hand, and with the other hand, you're sort of stirring the pot and doing these different kinds of exercises. Really easy to do, but all my shoulder dislocations, I print these, any kind of shoulder injuries, you want the people to be doing the Codman's. Last topic, proximal humerus fractures. We see a ton of these. These are more typical in elderly patients. The forces tend to get transmitted all the way up to the proximal humerus when they fall. Instead of getting Fuchs injuries in the wrist, they'll tend to get these proximal humerus fractures. that can be comminuted. The majority of these, unless it's big time displacement or big time angulation, most of these can go home in a sling as well. The only exceptions to that is if you have a fracture and a dislocation, they can be unstable, I would call ortho, because you don't want to be pulling on those shoulders, getting it back into place if they have a concomitant proximal humerus fracture. And then the last kind of humerus fracture that's important to know, tends to happen in younger patients, is a midshaft. You have to do a really good, on the proximal ones, you want to do a really good axillary nerve exam. On these midshaft ones, the radial nerve, they can get wrist drop. You really want to be checking for wrist extension, and these can go at home in coapt splints and those kinds of things. Okay, so that wraps things up for the shoulder.